This second talk by Barris, who unfortunately couldn't be here due to dental problems, he's doing better, I just talked to him, is about detecting recurrence on mpMRI. And he has similar disclosures to mine, but he presents them in this way, which I really can't understand, so you're on your own. So some facts about BCR and prostate cancer that I think most in the room are familiar with. The 10-year biochemical relapse-free survival rate is 65 to 80%, meaning 20 to 35% recurrence rate. We look for BCR after radical prostatectomy with a rising PSA, with well-known thresholds, and radiation therapy using the Phoenix criteria, among other criteria. And as this meeting is fully disclosing, there's still a large debate about how to do this with focal therapy. So he and I have been very impressed with this view of prostate cancer, sort of big picture view that Dr. Palapatu put out and his colleague Dr. Sweeney put out a few years ago, just sort of back of the envelope look at prostate cancer. So if you look at the 220,000 men at that time that were diagnosed, most of them had low and intermediate risk disease and are going to do really well. And then some of them had clinically localized or high risk disease. So about 33,000 of those men. And they generally go on to therapy, and approximately 26,000 of those men will relapse after primary therapy. Some of them, a small percentage, are going to start with metastatic disease and obviously progress to usually to death. I mean, almost always to death. So that group is difficult to do anything about. But they made the point, and I think it's good, that if our last chance of success in terms of cure is at this point. Beyond this point, as we go to metastatic disease, the chance of cure goes to near zero. And detecting relapse early and successfully treating it is therefore an extremely important decision point in the life of a man with prostate cancer. So being able to do this well is extremely important. And I think over the years we've begun to become more convinced of MRI's ability to detect local disease. It's definitely going to be supplemented by PSMA, but PSMA is somewhat limited for local recurrence because of the presence of the bladder and the huge bladder activity. So here's a typical example of a recurrent disease on MRI with low signal on T2, and you can see a nice ADC defect, and this is probably the most important thing, hyperenhancement. And so this is a fairly large local recurrence in a man after radical prostatectomy. So how about radiation therapy? So this is a man post proton beam treatment. He has a strong family history. And so the image on the T2-weighted scan has this kind of bland appearance. It's not super bright PZ, but that's typical of post-radiation, post-ADT prostate gland. Even at that time, there was an abnormality seen in the seminal vesicle, which of course is retained. The original tumor comes into view on the ADC, so it's still present despite the proton beam, and it's lighting up, which indicates activity. And so is that's the primary lesion still lighting up on a color map. But I can add that the seminal vesicle invasion also was there. So this is post-radiation. Dr. Pinto biopsied this, and of course it's post-radiation, so these Gleason scores are a little bit suspect, but nonetheless, there was clear recurrence at those sites. What about brachytherapy? So here you can see the seeds within the gland on this T2 weighted scan. Let's see. And when you do a full cycle through the entire complex, you can see the seminal vesicle invasion that's got all the characteristics. Here's the ADC map, here's the high B, and here's the high B, and here's the DCE. And so it's a recurrence not within the gland, but in the seminal vesicle in a patient with brachytherapy. So naturally, of course, if you just did, like was done, a routine 12-core of the prostate, you're not going to pick that up. Another patient with brachytherapy, again, the seeds are a little harder to see, but you can make them out okay on the ADC. And, you know, the gland itself is quite dark. But when you do give the contrast, so just to be clear, this is ADC and high B and the contrast scan. There is enhancement in that spot, indicating recurrent disease in the gland itself. So recurrent brachytherapy. And another patient with brachytherapy, just to tie this into our course title, our symposium title, the focal therapy. So he goes on to focal therapy, and another patient goes on to focal therapy, and you can see the defect from the focal laser ablation, and then 1 year post, and he's doing fine. And then finally, this is heavily weighted toward brachytherapy, I see, but another patient, so brachy 8 years prior for a significant disease, Gleason 4+4, and so you can see that there is a huge lesion that's developed in this prostate gland on the ADC. Very hard to see on the T2 because all the normal landmarks of the T2 are interfered with by the previous radiation, but no doubt about what's going on these scans. A patient with cryotherapy with recurrence. So virtually anything that you can think of in terms of a scenario with recurrent disease, you can evaluate with prostate MRI. The game changer will be PSMA because it adds some specificity to all the findings that I'm showing you. So the MR is really quite good from a sensitivity point of view of detecting recurrence, but its specificity is not that high. So you can pick out that there's something funky going on in this gland, but it's subtle and it could be a false positive. But once you add the PSMA into the situation, you can see there's a focal hotspot that we were able to direct a needle into to show recurrent disease. So I think this agent is coming on strong. We happen to have availability of it in our center. There was some hope that we could do all this with diffusion-weighted imaging, high B diffusion-weighted imaging, because lymph nodes tend to light up on that sequence. And here's an example of a patient post-prostatectomy. And we're using an endorectal coil here, but there's no prostate, but there is this soft tissue density adjacent to the rectum, which is very bright on the high B value image. But it really becomes trivial on the PSMA scan, because it's just lighting up there. And you don't have to have any guesswork. It's exactly a local recurrence. So poorly differentiated prostate cancer. So the multiparametric MRI involves 3 planes of the anatomy with T2 weighted imaging. It involves the standard diffusion maps and DCE MRI. We like to use an endorectal coil in this situation because we want to maximize the amount of signal from what could be a signal-starved situation. And Barris is very dogmatic about this, so it's underlined. But we think it's a very good, important adjunct. So, conclude. Early detection of residual recurrent disease is obviously important for cure. And mpMRI, although, at first it didn't seem like that great a detection tool, turns out to be pretty robust. And especially when used in combination with PSMA, I think it's going to be dynamite. It's sensitive, but not that specific, and that's where the PSMA scan will come into play. And the use of endorectal coil and a full multiparametric MRI, especially with the DCE, will really improve your results. So, and this is just a pitch for the molecular imaging, which is already having an impact. So thank you very much.